Without any further ado, I'm going to introduce the chair of the GPC, Dr. Chaand Nagpaul. We're very happy to have Chaand here, and I think you'll find it very interesting, and there'll be some scope to ask any questions that you might have as well. So, Chaand Nagpaul.
Can you all hear me? Right, first of all, just to say that it's an absolute pleasure to be following Roger, because Roger was a mentor, a guide for me when I first joined my LMC back in 1990. He was the GPC representative and was an inspiration. So thank you very much, Roger, if you're still here, for bringing me to medical politics. I also want to just credit Michael and all the team at Nottinghamshire LMC for putting together an excellent programme. It's relevant, it's forward-looking, it's there to support GPs, general practice, and all the staff who work within it. And well done, and I hope you have a great day. I'm going to be today covering a range of areas, starting with the context that we're working in, and I'll sort of, at the end, talk about how we, GPC and LMCs, can work more effectively together. Just give me one second, there's a... Right, we're back in business. So I'll be covering a range of areas today, and I'll finish off with how GPC, our national committee, and LMCs can work more effectively together. It's worth starting, or rather crucial, to start with the context, the financial context and the state of the NHS, which, as you know, is based around the 5-year forward view, not the GP forward, the 5-year forward view, announced just over 2 years ago, which promised an £8 billion investment in the NHS over 5 years. But the problem with that was that the NHS was at the same time asked to make a £22 billion saving, which is not just unprecedented, but actually arguably impossible to achieve. So you were being given a little bit, but having a huge amount being taken away. And even the £8 billion more recently has been questioned into looking like £4.5 billion in reality. It's not just the NHS. You all know from recent months that we've had brutal cuts to social care budgets, and that also impacts directly on our work as GPs in terms of our older patients not receiving the level of services that they need. There's been widespread agreement about the problems in funding of our health service, We all know that the UK spends less on health than virtually any other developed nation. We have fewer hospital beds, fewer doctors per 1,000 patients, with fewer district nurses, fewer GPs. Wherever you look, we're trailing the rest of the developed world. The Health Select Committee last year wrote a letter to the Prime Minister. We've seen Simon Stevens, some of you may have seen him appear at the Public Accounts Committee waving a newspaper article saying that headlines saying how we are actually woefully underfunded compared to other developed nations. And in spite of all of that, we have a government, we have a Prime Minister and Chancellor who seem to be in denial about this reality. There was no mention about the NHS in the autumn statement, and we really do feel we're up against a financial brick wall. And it's not just politicians, you've also got all authoritative opinion, King's Fund, Nuffield Trust. There is a recognition that the NHS cannot continue to provide the sort of care that the public need on the sort of inadequate budget where we have. And that's the climate that we're all operating in. Within that climate, we do need to nevertheless do our best to continue to survive. And we have been negotiating changes to the GP contract. I would have loved to have announced those changes to you today, but there's been some delays, so I won't be able to say much about them, but we've tried to focus on what matters to GPs. We have the GP Forward View, which I'll be talking about in more detail, because that is the package of investment from NHS England, and we need to make sure that every penny of that, all of that commitment, all of that resource reaches the front line of GP practices, because we know how the NHS traditionally implements any initiative in a way that creates problems and obstacles. So we do need to make sure that is delivered, and we need to be determined about that. And we also need a future for general practice based upon what GPs actually want, and we conducted a big survey that's given us a lot of interesting information, especially given, as you heard earlier, we have a very diverse workforce and GPs want different things, and we need to create a model that embraces that. Very different from my experience of only having been a partner for the 27 years I've been a GP, but we have different aspirations. In terms of the GP contract, as I said, we are concluding this, and you should hear about this very soon. But just to remind ourselves that this is a revision to an annual contract. It's not like for the junior doctors or consultants, it's not a major change. And it is a headache, and the LMC conference itself was frustrated at this annual change to our terms in the way in which we're paid. So we've been very mindful of that in our negotiations. We also know that the contract changes won't sort out the crisis, the problems in general practice. For a start, 50% of the workforce are not directly going to be affected, not directly affected by the contract changes to practices. There are huge amounts of pressures that we have that fall outside the contract. In fact, probably a bigger issue isn't what we're asked to do within the contract, but the scale of work that we're doing beyond the contract, which is either inappropriate or isn't resourced. Additionally, increasingly, the monies that we receive outside the contract, local commission services, can have a bigger impact. So we have areas where enhanced services budgets have been slashed by, say, £6 a head because of CCG pressures, and that's going to have a much bigger impact than the sort of smaller sums of money that we are working with within the contract itself. One thing we've been clear about, and I want to reassure you, is that in spite of all the government pressures, we have up to date not entertained any change to our contractual opening hours, and we're not going to accept negotiations around contractually increasing our capacity, our hours of opening, where we really manifestly cannot cope with our current workload. This slide just shows the scale of environment around the core contract, starting from a sessional workforce that sits outside the direct contractual arrangements we work under. You've got secondary to primary care shift, you've got community nursing, impact on general practice, mental health services, pharmacy. Patient demand is a huge issue. that affects us. We've got increasing collaborative structures that sit outside our contract, social care, and of course CCGs themselves in terms of local commission services. And so the contract is one part of a much bigger environment, and that whole environment needs to be addressed if we are to address the challenges facing general practice. Let's go page up. You're all aware of the comments that the Prime Minister made, the intervention, I think just around 2.5 weeks ago, effectively blaming GPs for the crisis in the NHS and also threatening to withdraw funding if we didn't open over 7 days. Now this, as I think was clear to all of us, was an attempt to deflect blame and to scapegoat GPs and focus attention away from the government's own responsibility in terms of the state of the NHS. And I believe that we did a very good job of rebutting that in the strongest of terms. We were all over the media for the whole weekend. I started from 5:30 in the morning on breakfast TV right through to the 10 o'clock news. And in fact, all the headlines on the news, the headlines on the radio, headlines on online media were about actually our message, which is that 1 in 3 GP practices have unfilled vacancies permanently, that over 8 in 10 GPs believe they cannot provide safe quality care because of the pressures they're under, that we're seeing about 300 practices going to close this year according to our own figures. And those were the messages that came out. And in many ways, we certainly could not have afforded the level of media publicity and the television advertisements to be able to advise the public of the real state of general practice. And so we believe we actually successfully managed to turn that to our advantage in a way to help the public understand the pressures that all of us are under. Some other specific issues that I'll just run through. One is the SBS debacle. Some of you may be aware that SBS, the previous primary care support services, had a backlog for about 3 years worth of hospital and other correspondence, which is now being sent to GP practices belatedly. We have negotiated compensation, and that payment will be made to practices based upon a scale of work involved. Another area was TPP. I don't know if any of you are TPP practices, or any of your TPP practices, a few. And you'll be aware of an error in their Q-risk calculation for patients at risk of CHD, and that workload of having to re-input that data will also be reimbursed, and we're just finalising that. And of course the whole fiasco with Capita and the huge workload that's incurring for all of us, especially our practice staff. We are in negotiations to receive reimbursement for practices about that, as well as negotiations on ongoing work such as the bagging of medical records. So we are doing all of that. I want to focus a little bit on the GP Forward View because it is NHS England's package of support, financial support for general practice. That's what we are working with, whatever our personal views about it. It does offer £2.4 billion of recurrent funding over 5 years. And I think these headlines can be a bit misleading because some of that funding would ordinarily have been part of our annual contract investment, but it is more than we received in the previous 5 years. And that's not to be confused with a separate £500 million non-recurrent transformation fund in the GP Forward View. So there are 2 pots of money, one the recurrent and the other the non-recurrent. If this money, if the recurrent spend is achieved, that will take general practice to over 10% of the NHS budget, and any local CCG investment for shifts of work into primary care, if that occurs, would add to that. Just to say that the investment in general practice will be at 14% in real terms compared to 8% in the rest of the NHS. Now, so therefore there is some recognition of prioritising general practice. But ultimately, the problem is, as I said earlier, that the cake is too small. Having a bigger slice of an inadequate cake still isn't big enough for the population's needs. It's also of note that the issues in Northern Ireland, where there is plans for mass resignation of GPs, is predicated on the fact they have no forward view. They have nothing actually on offer for support for general practice, and what they are arguing for is a similar package to what we have in England. I'm going to run through some of the headlines in the forward view, because what's absolutely crucial and critical is that it is a myriad of pockets of money. It is bureaucratic. It's all of those things. But what we cannot do is allow NHS England to say they have this money and to find that money being squandered because of implementation failures. And we have a job and we have a duty, certainly at the centre, and also LMCs have a duty to make sure that we hold NHS England to account collectively. The first is the Practice Resilience Programme, which went live late this year, which has £16 million available. And as we speak, that money should have been made available and practices notified. And I don't know whether that's been the case here, Michael. Have practices been notified?
It's been very mixed.
Mixed. Well, we need to know, because if this is not happening, we will certainly fight your corner at the centre. Again, we cannot allow this money to be squandered like the vulnerable practice scheme that never really took off the ground. Indemnity fee increases is in the forward view, and we're negotiating compensation for practices, GPs, for fee rises for next year. You know that the winter indemnity scheme is in place now, so GPs doing any extra sessions for out-of-hours care will have that indemnity proportion reimbursed. And there's also a group that's been set up for longer-term solutions to GP indemnity costs, which have rocketed, and there are issues around legislation and changing the whole way in which complaints payouts are made for claims, and that needs to be addressed. And there are ways in which NHS England are looking to reduce that burden. CQC expenses, as you know, CQC have announced an extortionate, unjustified increase to our fees, and we are negotiating to ensure that that rise is recompensed so that practices don't suffer financially, and that's in the forward view. The GP Development Fund I'll be talking about later has money associated, again, unfortunately, in different pockets. Part of it is the 10 impact areas, and we need to make sure that we know where that money is and that practices get that resource. Transformation monies will come on stream from April 17, and it's really important to flag this up at this stage, because those transformation monies will be just over £3 per head. That is a requirement for every CCG to make available over 2 years. And that money will be enabling practices to work together at scale and in a way that you should be choosing to do. And it's vital that we flag that money up. LMCs make sure that those conversations occur with CCGs, and in fact CCGs are meant to have, by the 23rd of December, put forward their plans on releasing that resource. Mandatory training, you all know that GPs are getting plagued by increasing demands on mandatory training, and our CQC requirements and our appraisal folder is full of that. We want to look at that afresh, because we think we're getting to the point where it's becoming highly deprofessionalising, and we're going to be doing some work with the college to address that, and that's in the forward view. And we also believe that self-care has an important part to play in managing demand in general practice, and we're working to a national patient self-care programme, which is in the forward view. Talking about access, there will be £500 million recurrently available by 2021 for extended access. And if you remember all the sort of challenge fund sites where the money was for 2 years, well, we have negotiated that this isn't money for a limited time. This will be in recurrent resources for general practice for extended access. Now, given that we have a government manifesto for 7-day opening, what we have managed to secure is an end to the language of 8 to 8, 7 days a week. There is no mention of 8 a.m. to 8 p.m. openings 7 days a week in the forward view. We managed to ensure that wasn't there. And more importantly, we have secured that the opening hours on weekends should be determined by the Commissioner based upon local needs. It would be scandalous to see GPs, as they have done, sitting in empty waiting rooms on a Sunday afternoon, when in fact we don't have enough GPs attending to the urgent needs of the elderly housebound in out-of-hour cooperative shifts, for example. So there is no requirement to be open beyond patient need. We've also negotiated that the extended access should include urgent care. So if you wanted to be to really use resources sensibly, you would integrate your out-of-hour service with that service rather than having two parallel services. And also, the extended hours is able to support in-hours general practice. That's all in the forward view. That's the language we have changed, and it's important that we understand that and we don't get seduced into a political agenda and convert it to an agenda of our own making. And I'll talk about that later, because there are opportunities to use that resource for some overflow work that can support in-house general practice. Primary secondary care interface issues have dogged us ever since I've been a GP, and we, for as long as I can remember, suffered the effect of workload dumping from other sectors of the NHS. And what has been achieved in the forward view, after huge lobbying from us, is for the first time recognition that there needs to be action taken against inappropriate and unresourced work moving into GP practices. So as of last April, we have got in the hospital contract a requirement to stop sending GPs letters to re-refer patients who've missed a clinic appointment, to stop sending GPs letters to re-refer a patient from a rheumatologist or an orthopaedic surgeon for internal referrals, to stop letters asking us to chase up investigations that clinicians in hospital requested. All of that actually wastes around 15 million GP appointments a year. That's 15 million patients who could have seen a GP, but these appointments were blocked for inappropriate reasons. And also ensuring that we get letters from hospitals within timescales that are appropriate, such as within 14 days for an outpatient clinic, and enough drugs when patients are discharged. Now, all of these contractual requirements, which are actually breaches if a hospital doesn't fulfill them, will not just happen overnight. You don't change a culture of decades in one moment. So that's why it's vital that LMCs, together with GP practices, push back and report such breaches. We've put a lot of effort in trying to make life easier for you. We've produced templates on our BMA website, which can be downloaded onto your clinical systems. They've been tailored for all the clinical suppliers, so that at a press of a button, you can produce a letter that goes back to the hospital saying that they have asked you to do something that is outside the that has breached their contract. We're asking you to then report those instances with anonymised patient details to the CCG, and also let your LMC know. And we want to be able to go to put national pressure to NHS England, who have already written to hospitals twice to comply with these standards. But there is a collective determination we need to have to make sure this is implemented locally. It won't just happen overnight, not least a hospital is made up of a myriad of scales of doctors, from junior doctors who may not be aware, so this requires a major culture shift. So we've done all of that for you, and we've also given LMCs template letters to write to their providers and to the CCG. We've also taken that a step further this year, and part of our urgent prescription for general practice is a raft of measures to reduce inappropriate workload on GP practices. We've got further proposals that any problem with a hospital should result in a helpline where a patient goes straight to the hospital, doesn't come to us to talk about why they haven't had the follow-up MRI from the last clinic appointment when they said it would be in 2 weeks and now it's 2 months on. And all of that stuff that completely wastes our time, wastes our staff time, In fact, to be honest, we look at our lives as GPs, but it's actually our practice staff and the money we spend on our practice staff that isn't being spent on the services that we should be providing for our patients. So that's something we're pushing for, and we want it in a contract. We want to make sure that it is a breach if we don't get letters from hospitals, and the standard we're looking for is 10 days and moving on to 7 days the year after. Prescribing is a huge issue for us, and again, it affects the entire practice, from the receptionist getting a sheet from a hospital asking us to prescribe a drug for a patient we haven't seen, for a condition we don't understand, without a letter, or in fact a specialist medication. So we're looking at a national standards and national directives to put an end to inappropriate requests on GPs, to make sure that shared care protocols are voluntary, and if you expect GPs to share in the workload, you've got to share in the resource, and that resource needs to be paid to practices. We're looking at national standards, national contractual levers to make this happen, including a push that we put forward that hospitals should have EPS, so that there's no need for them to come to a GP practice when they get a result of a chest x-ray 2 days later that shows consolidation. That hospital doctor should be able to contact the patient, issue that prescription at a pharmacy of the patient's choice, not having to contact us. So these are the measures we believe need to be implemented, as soon as possible. Workforce is a big issue. We know that we are several thousand GPs short. The GP Forward View does talk about initiatives to improve GP recruitment and retention. And I just want to be fair to some of these. They have been positive. The induction and refresher scheme is hugely better than anything we had before, and there are some doctors coming through that scheme. There was recently a GP targeted training program launched, which allows doctors who may not have gone through traditional training to be fast-tracked to become GPs, as well as those that may not have been successful in previous college exams. And there will be an improved retainer scheme announced, which we hope to announce. Some initiatives, I think Lincolnshire are somewhere here today, but they're piloting recruiting doctors from the EU. We've just seen, on Monday, the launch of a mental health support program for GPs because of the stresses we're under, a bursary for doctors who will work in certain under-doctored areas. So there are some initiatives, but ultimately the problem is that we've had 10 years of ridiculous workforce planning, where, even to quote Simon Stevens, he used the word crazy, that we saw a threefold expansion in hospital specialist numbers compared to general practice. So we've actually, living the damage of 10 years of illogical, ill-thought workforce planning, and we just don't have enough GPs as we speak. At a time when, in fact, in the last 10 years, we've seen a huge expansion of work moving out of hospitals into the community, the total opposite. That means that we have to look at other professionals supporting us as GPs, doing some of our work, because if we don't look at that, we just won't have the ability to carry on month after month. And that's why we do need to look at these initiatives, such as practice pharmacist schemes. And you can't generalize, because it all depends on the pharmacist. It's something we're learning increasingly, but there are examples where practices who cannot recruit are finding support from pharmacists, and as you know, the funding for that has gone up to £112 million, a fourfold increase, so that we end up with one full-time pharmacist supporting 2 or 3 practices. Physicians Associates, I'm as sceptical as any of you, but I'm told that I've met a few GPs who are piloting this and saying they can support their practices, so we're looking at that as an option. And also we know, or we've been told, that there'll be mental health workers supporting our practices, and if we don't have to look after or have to deal with the increasing numbers of patients with stress-related problems, that will help, but again, it all depends on whether this becomes a reality. There's evidence that patients can have direct access to extended scope practitioners, some good work done showing in some practices where patients can go to see a physiotherapist rather than seeing a GP for all sorts of muscular skeletal problems, reducing number of GP appointments, and these are initiatives that we are, of course, looking at and are in the GP Forward View. There is resources for training of practice managers, there is resources for nurse development, reception, training and signposting. I come back to the problem, these are all pockets of money, and there's a huge amount of work that we have to put in nationally and at an LMC level to make sure this money, as I said earlier, is not squandered and it reaches the front line. These are small sums of money, and it's important to work collaboratively so that there is training that occurs across groups of practices, because otherwise the money is too small at an individual practice level. And there needs to be, that I was speaking to Michael earlier, there needs to be the headspace. The problem with a lot of this is you need the headspace to have the time in order to save time. And so there is, some of this resource needs to be spent on backfill to allow practices to release staff, to be involved in creating these initiatives, and even perhaps having sometimes a project manager to work across several GP practices. For example, an initiative on workflow redirection, where we know it's possible for up to 80% of clinical correspondence to not have to be read by a GP themselves. So those are the sorts of examples that need, as I said earlier, resources but headspace. That is all part of the general practice development program in the forward view. Again, it gets confusing, these terminologies become confusing. That has that 10 impact areas is part of it, the training for staff, reception admin is part of it, development. So one of the other new initiatives that will come on stream next year is funding for web-based consultations, which is Ask My GP and Web GP. I don't know if any of you are using that in your area. Any hands? Well, you're not. So that resource will be available. I have spoken to practices who use it. There are several in London, and they claim, the ones I've spoken to, that it has reduced the number of GP appointments. Now, it may not work for everyone, like telephone systems and telephone consultations don't work for everyone, but it's a resource that we do need to make sure we avail of if that is something you feel will be useful. Now, I said earlier that LMCs are absolutely critical because all of the forward view initiatives that I've described, we at GPC are doing everything we can to hold NHS England to account. We've set up a dedicated GP forward view implementation group at GPC that is looking at the figures of spend in NHS England against these initiatives. We're getting feedback about what is going on in each area, and we're putting central pressure and oversight. And I also sit on a GP forward view oversight group that feeds back developments. The problem we have is that feedback comes from CCGs, and they can say what they like, and we know that in reality what they say and what happens on the ground don't often match, which is why LMCs are critical in telling us when things aren't going right. So if there are practices today that have not been given their resilience funding or have not been identified, we need to know, because we will take that up on your behalf, but we can't at the centre know what is happening locally. So that's critical. We've set up an LMC reference group, and Kieran, if he's in the audience, is part of that. We're getting feedback from regional areas about how the forward view is panning out or how it's not and what the problems are. Again, we brought LMCs face to face with the top table at NHS England, because otherwise they wouldn't understand the reality of the disconnect that we're finding between what the centre at NHS England says and what area teams and CCGs do. That has been the biggest, I think, eye-opening bit about this process, is that there is a real disconnect, and even when the centre wants something to be done, it's often down to the vagaries of local implementation that's the problem. We've actually tried to be as helpful as possible, so we've sent to all LMCs a checklist of each of those components of the forward view that make you dizzy, but we've broken it down so that LMCs can tick with your input whether or not those initiatives and whether that funding has been made available, and also the timescales. We've also now got an audit form so that we can be told on a monthly basis what is being delivered, because if we don't know about it, we can't act on your behalf. And the various funding streams in the forward view are outlined in a focus on, which is on our website. Please have a look at it, and US practices will know what you're entitled to. GP premises is an issue, and in the forward view, I'm not our premises lead. We've got some experts. It gets quite complicated when you start talking about leases, but I'll tell you what I can. We are still, unfortunately, we haven't yet concluded the premises cost directions. but when they are concluded, it will have provision for 100% reimbursement, but I must qualify that for certain categories of projects. The NHS property services lease has been agreed with some support for practices in certain areas, including some transitional relief for practices that sign new leases. There are big problems with regards to the transition to the new to property services in terms of their service charges. We're aware of that. We have a dedicated group dealing with this, and I'm happy to take forward any specific comments you have later on in the questions and answers. An important part of dealing with the pressures we're under, given how I described to you the financial brick wall that isn't just about general practice, it's the entire health and social care system, is that we need to therefore look at how we reduce workload and reduce demand, in the context of this financial brick wall. And we know from NHS England's own commissioned work that up to 1 in 4 GP appointments are avoidable. Something that all of you will recognise. When patients come and see you, I mentioned earlier that the inappropriate hospital demands, but there's a raft of examples in this pie chart of why patients see us and may not need to see us, both in terms of self-care, self-management, but seeing other parts of the system instead. So that's a critical part of managing our workload. We've provided a range of support material on our website, Quality First. Please, I would urge every practice to look at this. It has a range, it's a dynamic website, so we're continually updating it. For example, we've just given an update on GP seeing patients with dental problems, which we should not be doing, for instance. So there's a range of measures, including self-care initiatives, that practices can look at as tools to reduce workload. And a lot of it is also about pushing back on inappropriate demands. So we have template letters on an inappropriate request for a specialist prescription, for example. So there's a lot of material there. It is updated continually. Please use it so that we can liberate, if not a quarter of appointments, we can liberate a substantial number of appointments. And if you think about it, even if we liberated 10% of our appointments, that's the same as increasing the GP workforce by 10% in terms of GP appointment numbers. I said earlier that we've just concluded a major survey of the profession across all contractor types, so that we have a better understanding of how to develop general practice in the future. And what it shows is that GP partners, not surprisingly, are under the greatest of pressures. Only 6% of partners feel their workload is manageable, compared to 12% of salaried GPs and 34% of locums. And in many ways, we're at real risk of the entire partnership model breaking down, because this is not a sustainable pressure on GP partners. They're taking on an ever-increasing responsibility, and I experience it with a diminishing pool of other doctors who can carry that workload and responsibility. 1 in 3 GP partners are looking for alternative work. So this is, we are on a precipice where the partnership model could break down in parts of the country completely, and why we do need to find ways of supporting the pressures of those who run their practices. And about 8 in 10 GPs support incentives to support GP partnerships and provide incentives to become partners. But we also know that GPs want alternative career options, and that's absolutely legitimate. GPs are willing to work in new care models, so whatever I or we say about these new arrangements, we know that about a third of GPs are willing to look at working in those models, including in MCPs. We know that when we ask GPs, what do you want to help you reduce your workload, I was quite surprised that self-care was the top priority. They felt that there was scope for patients to manage their own conditions, both acute and chronic conditions, more effectively. And also they wanted more nurses supporting practices to look after their elderly housebound. I would have expected different responses, but that's what we found as the top 2. We also were interested to find that when we asked practices, GPs, where do you want new resources put in? Only 28% wanted all that money going into Global Sum. They actually wanted resources for staff to support GP practices, skill mix, and that's the messages we got. So it comes back to that diagram I showed you earlier on. It's the environment that general practice is under siege with, that needs to be supporting us, and it can't all be done from within our walls. It has to be also be supporting us from outside our walls. We asked, in fact, a question on what action would practices be willing to take to reduce their workload. So you know that we didn't ballot for industrial action, but we did actually produce a focus on industrial action that was sent to all LMCs, and I wrote about it in my newsletter, talking about what legally practices can do should we ever in the future take industrial action. Now, one of the things which we cannot do, unlike our hospital colleagues, is reduce our essential services. If you did that, you'd be in breach of your contract. So we don't have that protection that our hospital colleagues have. But there are things we can do, such as suspend registrations, such as stop going to CCG meetings, and we made a list of measures that our lawyers told us we could do. And when we asked practices, what would you consider stopping doing? Unfortunately, we only got a minority response in each of them. And for whatever reason, our biggest obstacle we find nationally is that GPs are very nice, and I think we are inherently wanting to please our patients, and in 4 exams, so they want to carry on providing voluntary work that's not even resourced. And I have that same battle in my own area when, as an LMC, we tell GPs quite clearly to resist and say no to inappropriate workload. We still find GPs going to training sessions to prescribe specialist drugs, which we're not even resourced to prescribe. So I'm just giving you figures that we have got. So we did actually ask the questions around industrial action in a covert way, and these are the responses we got. We believe, nationally, GPC believes, that one of the key ways to support general practice is for practices to work together and support each other. We know individual practices are vulnerable. I talked about the shrinking partnership partners in a practice. It just requires, in many cases, just one partner to fall sick, and like a deck of cards, it all just collapses. The regulatory pressures are always hovering above us, the employment responsibilities, so we're all vulnerable, and it's a fragile arrangement, and working together, we believe, is a way of supporting and sustaining individual practices. We know that when we asked GPs in our survey, more than half of GPs believe that the future model is about practices working in collaborative structures, more so than the number of GPs who believe in supporting the current arrangements. So there is support for working together. But there's also strong support of working together, not just as GP practices, but in multi-professional teams. Again, a recognition that general practice needs to be part of a wider system of multi-professional working. And of course, needless to say, the reasons why GPs want to do this in our survey is to reduce workload, to provide reduced bureaucracy and increase sustainability. I'll run through a little bit about the MCB voluntary contract, which is one of the new models in the 5-year forward view. It's a population-based contract looking after 30 to 50,000 patients. So it's all about a population approach to resources and delivery of care. One of the things that we managed to achieve as GPC is ensure that you can retain your national GMS or PMS contract in an MCP, and 2 of the models, the virtual and partially integrated models, allow you to carry on with your national contract. So please let us not feel that this is about losing your national contract. The 3rd model, a fully integrated model, does mean that you would relinquish your contract, but the crucial point is this is voluntary. This is not something that's being done onto you. It's up to you, and you can say no, and you can say you want to be as much or little involved in this initiative, including, as I said, 2 models that allow you to retain your national contract. The virtual MCP is simply an alliance contract where you retain your individual organisations, community trust practices, working under an alliance arrangement to work together, providing integrated services for the community. It would, for example, offer the opportunity for community nurses to be working in an alliance contract supporting practices so you don't actually have the current divisions about whether the nurse does a flu jab on a caseload patient rather than a different patient on your list. So there are ways that we can use this to our advantage. In partially integrated MCPs, the practice again retains its core contract, but for the enhanced services and other services moving out of hospital, it would provide that through a separate contract as an entity, as a collaborative entity. And in the fully integrated MCP, practices would voluntarily lose their national contract and have a subcontract within their MCP working to an MCP contract. As I said earlier, we have huge concerns about this model because we believe there is enormous strength in the national contract, which I'll come on to in a second. This diagram just shows how an MCP could look like. So in that yellow area, which is the MCP, you have practices on the top in the squares which retain their core contract. So they still have a national contract, but they're part of an MCP providing collaborative integrated services. But you've also got the oval blobs, which are practices that are working within the MCP to a local contract, if they so choose to do. You've got community services, again part of the same larger square, because this service is integrated for local populations. There are huge concerns we have about moving from a national contract, because first of all, it undermines the whole concept of standard, consistent, equitable care across the country. Local GP contracts mean that you will lose national protections in terms of and conditions, and each local negotiation has increased bureaucracy. All of you on EMS contracts, my own practice included, knows what that's like. Well, that's just a microcosm. This will be a huge bureaucratic workload at a local level. There's been a lot of talk in these local contracts of getting rid of QOF, but let's not forget that if QOF goes, the monitoring of QOF continues. CQC and Primary Care England, NHS England continue with their web data dashboards of what we provide under the QOF headings. And if you then get rid of QOF and give it back to local areas to do another quality initiative, you're in effect working twice for the same money. So you need to be very careful that not to go down the path of thinking you're losing something, but actually still doing the work and then earning it back for more work. We also know that if you have large numbers of practices entering into local arrangements, you will just lose the negotiating power for those national GMS contracts remaining in an area. So there's a real risk for that. And also for the salaried GPs, employed GPs, if the salaried GPs are all under local contracts, that again is placing a risk on national standards that we would expect. So all of these are issues that need to be considered. So what should practices do now? With regards to the MCP contract, I would just reiterate, it's voluntary. You don't have to say yes to anything. Please don't be coerced. Look at the guidance that we've produced. There's a myriad of legal implications, organisational implications, what you're signing up to. So please read our guidance, get proper professional advice before you move into these arrangements. But the real message that we want to portray as GPC is that actually working together is your agenda. It's not a government MCP agenda. Do what you feel will work for you and draw upon the forward view transformation monies to help you have the resources and the headspace to work together. That is what that money needs to be resourcing. And LMCs should be part of that process of enabling a bottom-up approach of working with and for each other. It's our model. And I lived through the era when we couldn't cope, I couldn't cope with 24-hour responsibility, when I carried a bleep on every week and every second weekend, and I was shackled to my job. And we set up the GP cooperative movement. The government gave us some money, we took the money, clubbed together, and that revolutionised our ability to cope in 1995. Roger will remember that, he was part of the negotiating team. So we can work together, and we can actually resurrect that spirit of collectivism, of looking after each other, and that's what we need to be doing. And this is already happening. Forget the government, it's happening anyway on the ground, as we've seen federations develop. We know we've got areas like Manchester, now others, that are devolving health and social care. We've got the MCP agenda, there's something called primary care home, some of you will be aware of. We've got PACS ACO development. In some areas, practices are being run by acute trusts, and we've seen the advent of super practices and super partnerships, which I'll talk about in a second. So there is a range of ways in which the profession is already working in collaborative arrangements. And this just shows the advantages of working together to support practices, to manage workload and develop the workforce. So first of all, at the bottom tier of GP practices, the current GP contract already allows us to share staff, to share services, to cross-cover. And we don't do that. We could have one member of staff coding results on behalf of 4 practices before we, just under our current contract, using data sharing resources. So there is an opportunity already at a very simple level to support each other. But you can also create a structure above that, which is the blue block, where practices can as I said earlier, have management and back office functions supporting each other, reducing costs for individual practices. These structures can also be forming hubs, locality hubs, managing overspill work, patients beyond a certain number that we've seen. But they can also employ a multi-professional skill mix of workforce to support practice pressures. This entity, this collaborative entity, which can take the form of various forms, can integrate or work together with a community provider, in effect creating the same as an MCP, but developed on the ground, owned by the profession in a horizontal manner. And I mentioned earlier the issue about safe working. Well, the BMA GPC has put forward a model for safe working so that practices, when they're overloaded with the surges of demands that we all have, can send patients, the overflow patients, to a locality hub. And I'll describe this model is already happening in some parts of the country, and we've got a paper on our website that describes that. And it can move to a system where practices can have longer consultations, and that's what is crippling us, or really, that's what makes the day unmanageable. Now, you can actually work together in different ways. So these are just case studies to show that this happens. In Essex, they have an MOU, so it's not even a formal legal structure, but working together, they're already agreeing collaborative care home visits instead of each practice being responsible. They're sharing minor illness in centres on behalf of each other. They also having joint training I mentioned to you earlier, and already they believe it has reduced bureaucracy and reducing the workload. It's just started under purely an MOU of 9 practices working together. I mentioned the locality hub of safe working. Well, this is in Kingston, in Richmond, in southwest London, where there are 4 locality hubs where practices can book patients directly. The hubs have access to the practice's clinical system, and therefore practices overflow work is seen at the hub. There's an example we have in Kingston where a single-handed practice, the practitioner was in France, he had appendicitis, could not get back to his practice, the hub sustained his practice. The practice would almost certainly have had a breach notice, maybe even had its contract withdrawn, but it also gives you an example of how it can result in sustainability. If you can't get a locum, the hub can provide that service on behalf of the practice. These are locality hubs owned by the practices. They have control over the appointments. They have control of their workload being transferred when they can't manage. And they've got systems of using the service equitably. That's going to be a real dialogue when you have several practices. You can then look at something more ambitious in terms of legally and create a super partnership. In Birmingham, the Our Health Partnership has, I think, 33 practices, 280,000 patients. And one of the real strengths of this model is that you have a single partnership, jointly and severally liable, but the practices still retain their individual identity. So NHS England have agreed to carry on funding them separately, but they are collectively responsible. They have a single CQC visit. They have, again, the ability to look after each other's patients with data sharing, and they contribute a certain amount each for an overall board structure. This has not been going live, this hasn't been live for too long, but already they're looking at our locality hub model for safe working and longer appointments within individual practices. So you can do these things, and these models exist, and you can draw upon those examples to set up your own models. Now, all of this requires partnership between the work we're doing nationally and LMCs. We've certainly produced a huge amount of guidance over the last year. It's on our website. It's not the easiest website to navigate, but please look, we have got loads of material. We're using LMCs to support us in producing relevant materials, such as from Humberside LMCs, our GP4 review documentation. We've set up, I said earlier, a reference group with LMCs, bringing LMC regional reps in touch with direct head-to-head contact with NHS England. We're updating LMCs with much more regular bulletins every 2 weeks. We're holding an event for all LMCs. I hope Nottinghamshire will be attending on the 23rd of February, specifically on working at scale. And the examples I've given you are the sort of examples you will hear from GPs and practices describing how their workload has reduced working together. And we will also be holding another event in early April around the four of you to make sure that you can all be enabled to get hold of the resources that have been committed to by NHS England. This just shows you the scale of material we've produced in the last year. I think something like 25 bits of guidance that has been produced with specialist support. We've written numerous open letters on behalf of the profession that have been publicly available, have been reported in the press, standing up and representing GPs' interests. So in final conclusion, we are operating within a grossly underfunded NHS. We have a government that is not seeing the reality of the crisis, or it's not acting on the reality of the crisis. We also know that general practice is part of a bigger environment. We know the four review monies, however problematic it appears, we need to hold NHS England to account and make sure that's delivered on the ground. That can only be done if LMCs work with us nationally to deliver that resource. We need to have a sense of empowerment I was describing towards the end, empowerment to take control of looking after each other, to support each other, to sustain general practice. And that means working across with other professionals. And ultimately, it is about survival and sustaining ourselves for a limited period of time. Because I don't believe the public are hoodwinked any longer. I don't believe we can go into another election without head-on addressing the crunch issue that we do need more resources in the NHS. And I can't imagine any government trying to pretend to the public that we can carry on the way we are on a shoestring. And if that resource is made available, we need to be there as GP practices surviving the next couple of years so that we get that larger slice of, crucially, a larger NHS cake. Thank you very much for listening.
Thank you very much, Chaand.